Okay. Hi, everyone, and welcome to the IARS Virtual Education webinar. Today, we're going to be talking about the Crossroads of Hematology and Intensive Care Medicine. This webinar has received no commercial support. Just as a reminder, if you missed the 2024 annual meeting, there are on-demand recordings available for purchase. And for more information, you can visit the IARS webpage. Also, a reminder that the abstract submission is open. The deadline to submit is Sunday, November the 3rd. After this webinar, you can join other participants via the Doc Matter website. The speakers will be available for questions, and this is a QR code where you can access that. At the end of the panel, we will address a few questions from the audience. So feel free to send your questions via the Q&A box, and we'll do our best to cover as many as we can. And remember that there are upcoming webinars. On September, we have current controversies in critical care, and in November, we have global critical care, the crisis and way forward. So today I am very, very thrilled to welcome three exceptionally knowledgeable and insightful panelists. We know that in the face of blood shortages, we're really pushing the boundaries of patient blood management and anticoagulation. So these three speakers have a lot to say about that today. Our first panelist is Dr. Alberto Furzan. He is an assistant professor at Tufts University Medical Center, where he works as a cardiac anesthesiologist and an intensivist. And he will be talking to us about ECMO anticoagulation, and he's going to focus on the innovative approaches and some paradigm shifts that we have on that field. He is currently going to be in the ICU, so he pre-recorded this talk for us, and then he'll be with us for the panel as well.
Hello, everybody, and welcome. Before I start, I would like to thank the IARS for the invitation. My name is Alberto Furzan. I am a cardiac anesthesiologist and intensivist at Tufts Medical Center. And the title of my presentation is ECMO Anticoagulation Towards Innovation and Paradigm Shifts. I don't have anything to disclose. And I would like to start my presentation with a question. Why is anticoagulation important in ECMO? And to understand this, we have to discuss what happens when blood is exposed to the artificial surfaces of the ECMO circuit. On the left part of this image, you can see that when the blood gets exposed to the ECMO components, like the cannula and the oxygenator, the intrinsic pathway is going to get activated via complement factors 9, 12, triggering thrombin activation and fibrin deposition. Moreover, shear stress is going to cause hemolysis, and as a result, there's an increase in plasma-free hemoglobin, which itself is cytotoxic, leading to further endothelial dysfunction, and as well as vasoconstriction from nitric oxide consumption. And all this together will lead to platelet activation, creating a prothrombotic and a pro-inflammatory state. To make this process more complex, also these patients will experience coagulopathy due to an acquired von Willebrand factor deficiency, plus a consumption of all these coagulation factors and platelets, leading to an increased risk in bleeding. As you can see, the main challenge associated with current anticoagulation practices is to maintain this very thin balance between bleeding and thrombosis. If we look at the ELSO registry, you can see that the risk of bleeding in VV ECMO is 22%, and the risk of bleeding in VA ECMO is 30%. And although VV ECMO bleeds less, interestingly, the incidence of central nervous system and pulmonary hemorrhage is more common in VV ECMO than VA ECMO. Also, bleeding at the insertion time is more common in VV ECMO, likely from a rapid decrease in the PaCO2, together with the bolus of anticoagulation these patients receive. On the other hand, the risk of thrombosis is a little bit higher, For BV ECMO, it's 10 to 30%. For VA ECMO, it's 20 to 40%. And VA ECMO tends more towards thrombosis, especially on those cases with poor LV unloading during low flow states like weaning trials, or on the low flow segment between the return arterial cannula and the antegrade perfusion catheter. So we can see thrombosis is more common than bleeding, but bleeding usually carries a more significant or a significant higher mortality risk. And if we look at the temporal trends of bleeding in both modalities in the last 20 years, on the black line, we can see that total bleeding complication has decreased over the last 20 years, but this is mainly due to improvements in the surgical technique and the cannulas. But if we look at the yellow and the red line that represent GI bleeding and CNS bleeding, they have remained pretty stable. And we know that all bleeding is associated with an increase in mortality, raising very important questions. What can we do to improve bleeding outcomes? Do we need different anticoagulants? Do we need better monitoring? Are we being too aggressive with our targets? Do we need lower anticoagulation targets? Or do we even need anticoagulation at all? And this is what we're going to discuss in the next few minutes. All right, let's start with circuit components. Since exposing large volumes of blood to circuit surfaces during ECMO is unavoidable, there is a lot of advancements made to make these modern ECMO circuits less thrombogenic, reducing the need for systemic anticoagulation. So these improvements can be broken into three categories. The first one is the biomimetic surfaces. They're aimed to replicate the natural antithrombotic and anti-inflammatory properties of the endothelium. Examples of these are heparin-bonded circuits or nitric oxide bonded circuits. Specifically, nitric oxide inhibits platelet activity, but is not widely available. A second example is biopassive surfaces like PPC and PMEA. These are designed to create a barrier between the blood and the foreign surface of the ECMO circuit, minimizing the interaction that can lead to thrombosis. And finally, endothelialization is more of a research topic. It represents a very promising direction for ECMO, mimicking the native endothelium would decrease thrombosis, but currently is not technically feasible. Now let's talk about anticoagulation practices. If we look at the 2021 ELSO anticoagulation guidelines, we see this big disclaimer that says that these guidelines are intended for educational use to build knowledge of physicians and other health professionals. They describe what are believed to be useful and safe, but these are not necessarily consensus recommendations. And because of this, there are no standardized protocol on anticoagulation on ECMO. And you will see a lot of variability about different centers. So let's talk about what is the ideal anticoagulant in ECMO. Some of the characteristics we're looking into a medication is that that medication has ample experience in safety and efficacy. It should target both intrinsic and extrinsic pathway. It should be easy to reverse in case of severe bleeding, should be titratable, should have a short life, and ideally a reverse agent. Should be easy to monitor, should be predictable, especially in critically ill patients. It should be inexpensive. And heparin checks a lot of these boxes. So heparin, for decades, it has been the anticoagulant for ECMO. Currently remains the most common used primary anticoagulant on ECMO. And heparin itself does not have an anticoagulant effect. It needs to create a complex with antithrombin to inhibit thrombin and other factors. The half-life of heparin is about 90 minutes. We have the luxury of having a reverse agent, protamine, in case of severe bleeding. And it's mainly excreted by the reticular endothelial system. So if heparin is so good, why do we need to look for alternatives? Heparin has several limitations. One of the main limitations is that heparin only neutralizes free thrombin. It cannot neutralize fibrin-bound thrombin. So once the clot is formed, all that thrombin inside the clot is going to remain active, even on systemic anticoagulation of heparin. Heparin binds also to heparin binds non-specifically to a variety of other of plasma proteins. So it doesn't bind only to antithrombin, it binds to PF4, fibrinogen, and then this will decrease the amount of heparin available for its main target, which is antithrombin, leading to unpredictable effect in some patients. Some patients will experience heparin resistance, which is described as the inability to achieve a target anticoagulation on high doses of heparin. One of the reasons why this happens is for antithrombin deficiency. And one of the main reasons why we look for alternatives to heparin is this phenomenon called heparin-induced thrombocytopenia. And let's quickly review. As I mentioned, heparin not only binds to antithrombin, it binds to a lot of different proteins. One of those is platelet factor 4. And when PF4 binds to heparin, they create this very immunogenic complex. And once IgG is formed, IgG is going to start activating platelets, leading to a prothrombotic state in both arterial and venous. The incidence of heat Lockley is very low in ECMO. And the treatment is going to be stop heparin and switch to an alternative anticoagulant. What are the alternatives to heparin? So the most common alternative to heparin is the direct thrombin inhibitors. And as the name states, these medications directly inhibit thrombin without needing antithrombin as an intermediator. These medications have shown few advantages over heparin. For example, one of the main ones is that they will inhibit thrombin, both free and clot bound, unlike heparin. They have a more consistent and predictable anticoagulation effect because they go directly to thrombin. They have a shorter half-life and they do not cause hit. They're actually the treatment for hit. And some of the disadvantages are lack of a specific antidote. Although some centers report using factor 7 to reverse these medications quickly. There is lack of specific laboratory monitoring. And there is limited experience in ECMO. Most of the data is retrospective. The two medications that we most commonly use in ECMO is bivalirudin and argatroban. So let's talk about them. Bivalirudin is mostly metabolized by proteolytic enzyme, but 20% is going to be metabolized in the kidneys. So this medication will need dose adjustment in patients with kidney injury or patients who are on renal replacement therapy. On the other hand, argatroban is just metabolized by the liver, so we don't need to adjust the dose. Bivalirudin has a shorter half-life compared to argatroban. Both are monitored by APTT. And something very important about bivalirudin is that in cases of low flow state, bivalirudin is going to experience rapid local cleavage in these areas of low flow, leading to a spontaneous thrombosis. So we have to be careful on patients who have poorly unloaded LV or when we're doing the weaning trials. Bivalirudin is probably the drug that is most commonly used as an alternative to heparin. So most of the studies, all retrospective, comparing heparin and bivalirudin directly. This systematic review from 2023 looked about 1,600 patients, and they found no statistical difference between heparin and bivalirudin in incidence of bleeding and thrombosis. Actually, if you can see this table, some studies actually found a statistical significance favoring bivalirudin over heparin in reducing major bleeding, thrombosis, and the need for transfusion. And the thought behind this is that bivalirudin has a more predictable pharmacokinetic, leading to less supratherapeutic levels, achieves target anticoagulation target faster, needs less lab checks, leading to less anemia. All right, this third point is very important, as important as it is choosing the right agent. Another challenge we find is to decide on the appropriate target and what is the best testing method. So for the sake of time, I'm just going to briefly mention these tests. These are 3 traditional tests we probably all know about. I put these targets here. These targets can vary from among institutions, but this is what the consensus showed as the most common targets. And each test is going to have an advantage and disadvantage. So let's talk with the first test, activity clothing time. We all know this test is very widely available. It's inexpensive. One of the advantages is that it uses whole blood tests, so it will examine blood response to multiple factors. One of the disadvantages is that it's affected by clinical factors such as thrombocytopenia, hypothermia, and hemodilution. Although it's not approved for DTIs monitoring, and it's the test we will do for patients who need to go to the cath lab or on cardiopulmonary bypass. APTT, it's the most common test we use to monitor heparin. So it's a gold standard for heparin and for DTIs. The main limitation is that APTT becomes less reliable in critical illness when there's pro-inflammation or there's an inflammatory state, or when there is a presence of the antiphospholipid antibodies. Also, it loses its linear relationship at higher dose of DTIs. The third test, anti-10A, is a test specifically used for heparin. It's a functional assay. It specifically measures the ability of heparin to inhibit factor 10A. The main limitation is that it's a chromogenic assay, so it's going to be falsely low in patients who have hemolysis and elevated plasma-free hemoglobin, which is going to be most of our ECMO patients. And because these tests have some limitation, these three tests have emerged to overcome these limitations. We probably are also know about viscoelastic tests like TEG and Rotem. It's a wonderful test. It will provide a lot of information about the coagulation cascade, the clot strength, fibrinolysis. It's a point of care, so it's very easy to perform. Disadvantages is that there's a limited availability, although there's some data emerging about its use in DTIs. When we use TEG, it's going to give us different parameters. The parameter that we use to monitor anticoagulation in ECMO is the reaction time, or R time, which correlates with the initiation of fibrin formation. And then these two tests, the diluted thrombin time and the Icarian clotting time, have been designed specifically to monitor DTIs. They overcome the limitations of APTT because they are not affected by inflammation, and they also have a linear response to DTI concentration. So I hope we can see this test being used more commonly in the next years. And finally, let's talk about no anticoagulation strategies. As an intensivist, we all have taken care of that ECMO patient who is having severe bleeding, and we have to stop heparin. That makes us very anxious. Although it's reassuring that modern ECMO circuits reduce thrombogenicity. All this data is retrospective, so we have to look at it very carefully. But retrospective data suggests that the risk of thrombosis is similar between patients who are not anticoagulated and patients who are on systemic anticoagulation. Of course, if we're not opt for this strategy, patient selection is key. We have to avoid in patients who have a prothrombotic state, like heat or low flow. And the lack of administration of anticoagulation in ECMO is not a recommended practice due to insufficient evidence. So let's see what the evidence says. I found these two studies, both again retrospective. In terms of VV ECMO, this study on the left looked about 74 patients, half of which were on systemic anticoagulation, and the other half were only on DVT prophylaxis. And if they were holding anticoagulation, they were sure that they kept the flows rates over 3 liters per minute. And the other study for VA ECMO looked about 200 patients, and they introduced this important concept, this very interesting concept, saying that they felt comfortable holding anticoagulation if flows were able to maintain at a level that allows complete blood exchange in the circuit at least every 20 seconds, which is going to be the normal PTT in adults. Both studies have the same conclusions. They found similar rates of thrombosis and survival between patients on no anticoagulation ECMO and patients on systemic anticoagulation. They found less incidence of bleeding and less transfusion requirements, less hit on patients on no anticoagulation. But both of them agree that even though we're not using anticoagulation, these patients need frequent and strict coagulation status monitoring, as well as clinical surveillance of the patient and circuits to make sure there's no clot. So this data at least is reassuring for us if we have to hold anticoagulation in patients who are bleeding or are at very high risk for bleeding. And finally, my conclusions, ECMO is associated with a prothrombotic state and coagulopathy. So the management of anticoagulation requires a fine balance to prevent thrombosis and minimize the risk of bleeding. There's a lot of evidence supporting DTIs as safe and effective in ECMO in patients with or without HIT. So hopefully we can see some prospective data showing that these medications are possibly superior to heparin in some patient populations. Choosing an anticoagulant is as important as choosing the target and monitoring method. There is a trend towards using less anticoagulation on ECMO thanks to the modern circuits. And the lack of anticoagulation, as I mentioned, in ECMO is not a recommended practice due to insufficient evidence. But if we need to stop anticoagulation in case of severe bleeding, it would seems probably is okay. Thank you very much. And here's my email if you have any questions.
Thank you so much, Dr. Furzan. Our second panelist is Dr. Ian Welsby. He's a professor of anesthesiology at Duke University Medical Center in Durham, North Carolina. He's globally recognized for his work on anticoagulation and patient blood management, and he will be discussing the latest updates on anticoagulation reversal.
Hey, Ingrid, I need to be able to start my video. Okay. Let me just get this started. I'm going to share my screen. All right. Sorry, I could have been better prepared. All right. Specifically, we're going to be talking about the reversal of the direct oral anticoagulants. And there's been some recent data, which is really what we're going to be focusing on, not heparin and the others, but the apixabans of the world. Okay, so some disclosures and some acknowledgements here. You'll see a lot of the slides has got some ISTH logo on. That's the International Society of Thrombosis and Hemostasis. They've done some good lectures on hemostasis for the anticoagulant nerds out there. Anyhow, so one thing that's for sure is that the direct anticoagulant use is increasing. And be it, I mean, warfarin is decreasing, as you can see here, and the DOACs are increasing. In fact, the number of patients receiving anticoagulants, which is appropriate given the burden of AFib, etc., in our aging population, is increasing. It seems that apixaban, rivaroxaban are taking the majority of the market for DOACs, and dabigatran is sort of falling off since 2014. Dabigatran was the first, so it sort of started off, but we'll see in a later slide it has some side effects. So bleeding complications limit the oral anticoagulant use. Now this is true for warfarin as it is for the DOACs. And actually the major bleeding rate in real life usage is about 2 to 4% per year. And clinically relevant but non-major bleeding, so not life-threatening, not into a vital organ or space, is 10 to 12% per year, which is enough to have these drugs stopped, and certainly for the need to be very much aware of how to reverse these drugs, should you need to do urgent surgery or should it be life-threatening bleeding in a critical space like in the cranium. So having said that, the DOACs have got a better profile, better safety profile in terms of intracranial bleeding and major bleeding than the vitamin K antagonists, warfarin and Coumadin. However, they do have an increase in the gastrointestinal bleeding, which is the most frequent site of bleeding. And you will see more of these folk with GI bleeding coming in through the emergency room. And it will most likely, if they're unstable, into your ICU. So one thing you've got to be careful about is making sure that you really do have appropriate anticoagulation strategies, because they are different. And for example, for a mechanical heart valve, warfarin is indicated simply because there was one study published probably almost 10 years ago where dabigatran was inferior to warfarin. They had clotting of mechanical heart valves, which is obviously undesirable. And as a result of that, no other DOACs have been studied in this patient population. I guess nobody wants to take the risk, which is totally reasonable. Similarly, in the setting of valvular disease, so for example, AFib with mitral stenosis, the DOACs have not been studied extensively in this patient population and actually were excluded from the major trials, which were really just looking at AFib as an anticoagulant and certainly venous thromboembolism or VTE prevention in those studies. Similarly, there's significant metabolism in the liver and significant metabolism in the kidneys, so you can see that warfarin is preferred if you have severe hepatic impairment, although I know for a fact that some of our hepatology colleagues are sort of pushing those boundaries, particularly with the Pixaban, which doesn't seem to hang around for quite as long as rivaroxaban, despite the pharmacological profile suggesting otherwise. Certainly, it's moderate hepatic impairment. That really is where they're pushing the limits by using DOACs, because they're just so much easier to use in patients, particularly with liver disease, who bruise all the time. They don't particularly want to be stuck for INRs every week. Similarly, if you're stable on warfarin, you could have the choice. This was personally very poignant because my father was on warfarin and he was offered a Pixaban, but he kind of liked going to the warfarin clinic, which was unusual, but I guess he was just a sociable beast. So, sometimes you get surprising answers from your patients. Now, if your creatinine clearance is less than 30, so renal dysfunction, really those patients were not included in the DOAC trials. So many guidelines recommend against the use of DOACs in that population. Again, these rules have been sort of pushed. They're not recommended, but I think clinicians practically are using a Pixaban in this sort of situation, which can make it kind of difficult if you want to actually reverse it, and because these drugs will hang around a little bit longer, even if you reduce the dose. And this is total off-label usage, but you will encounter it in your practice. And one of the reasons why dabigatran fell out of favor was because you do get a lot of dyspepsia in this using this drug. And similarly, if you have GI bleeds, you would really not want to be on dabigatran. So a lot of patients will take themselves off because of the side effects. Right. Trying to move on. All right. So, hardly surprisingly, mortality is high after oral anticoagulant-related major bleeding, and in particular, focusing on intracranial bleeding. And that really is going to be the focus of this talk, is most of the data, not surprisingly, are in the reversal of anticoagulants in the setting of intracranial bleeding, because, rapid control of anticoagulation, restoration of hemostasis is particularly critical in that setting. And if you have OAC-related major bleeding, it's almost a 50% mortality immediate mortality within 30 days if hemorrhage. So this is a big deal, and we've got to take it seriously. So considerations when you're presented with somebody who is bleeding, be it intracranial or more commonly the GI bleeding, is did your patient take a DOAC? Now, some historians aren't exactly very accurate, and particularly when you come to finding out when was the last dose, certainly if someone's had an intracranial bleed, they may not actually be able to tell you, or certainly you may not rely on the history. And so you really want to know if there's DOAC still present. Now, not many places have the DOAC-specific anti-10A assays, but one thing you can do, which is interesting, is just the standard low molecular weight heparin anti-10A assay, or if you send an anti-10A assay looking for heparin levels, unfractionated heparin levels, most places can turn around one of these assays within 30 minutes. And it is kind of nice to know, certainly before you spend a whole bunch of money on andexanat in particular, that you may not want to reconstitute all the vials, because that's actually quite a laborious and drawn-out process. But you may want to be sending a test for an anti-10A level as you are determining the need to reverse the anticoagulation, just to make sure that you're doing the right thing. There's not a lot of point giving a drug that has the potential to be prothrombotic if your anti-10A level is 0. It is not quantitative if you do this sort of like a screening anti-10A assay, but it is qualitative. If it is 0, it's 0, but if it's positive, you don't know exactly what the level is. You have to wait for the drug-specific assay to come back, and we're fortunate enough to have access to that. But still, I think most hospitals will have access to some anti-10A assay, and that really can be useful in triaging patients who ought to get anticoagulation versus those who do not need it. All right, so this is a reversal algorithm that's been proposed in hematology literature. Here you are, you have a patient who's on a DOAC. If they're not bleeding, there really isn't a whole lot of things you need to do. You do not need to reverse that unless this patient has to have a needed invasive procedure, which cannot be safely performed while anticoagulated, in which case there is an indication to reverse. But you really have to be convinced that this is an essential procedure before you go ahead and do this, because there are risks associated with reversal, be it thrombosis or inadequate reversal and subsequent hemorrhage. If, however, the patient is bleeding and it's considered non-major, so non-life-threatening and non-limb threatening, not into a vital area such as anywhere in the CNS, or like, for example, pericardial tamponade, something like that, you just wait it out, and you may have to support them with some blood products. So I don't think it's very realistic to use DOAC reversal as an alternative to a unit or two of red cells. A, because of cost, and B, because it just the thrombotic risk may not be worth it. However, should you define this as major or life-threatening bleeding based on your clinical evaluation, reversal is indicated, and we'll come on to how you reverse things. So one way of reversing things, and this is important if you're able to wait, is that if you look at the pharmacokinetics of these drugs and you account for renal function, you can actually categorize these drugs, you can categorize the procedure that you're about to undergo as low or high bleeding risk. And this is the amount of time after cessation of the drug. For example, you could do a high bleeding risk case on someone who's, you do some like neurosurgery, for example, on someone who's got normal renal function taking dabigatran on day 3 after they've stopped taking it. And pretty much that goes for all of the drugs, because you're trying to get to sort of 4 to 5 half-lives to make sure that that they're out of the patient's system. If you have the luxury of being able to check an anti-10A level, you can always use that as a surrogate, or you could use that as belt and braces. So you just want to be doubly sure that that the drug is out of their system. All righty. And if you're looking at defining whether or not the drug is present, you want to look at the available assays. And as I alluded to before, the anti-10A activity is what you would be looking at for rivaroxaban and apixaban, just to make sure that it was out of the system. So you would be looking at basically measuring something that was below the on-therapy range. You can also see a change in the prothrombin time, particularly rather so than the APTT for the anti-10A, for the factor 10A inhibitors. But if you see a signal, if you have an abnormally high PT or prothrombin time at all, you've got very significant drug present and you're in the therapeutic range. If, however, your PT is normal, that is no guarantee. You have to look at the anti-10A activity. And you could even, if there's 0 anti-10A activity, you can have a minor amount of residual drug present, but it really is thought to be insignificant in that kind of setting. Now, if you're looking at dabigatran, you have to be looking at thrombin time. Now, most labs can do a thrombin time. The ECT is something that Dr. Furzan alluded to when he was talking about measuring bivalirudin. The ECT is not available in the US, so that's kind of irrelevant. Again, if you have a signal on the APTT, which is a more sensitive standard assay to dabigatran, if you have any signal, you're in and or above the therapeutic range. If you have a normal APTT, you still could be in the lower level of the therapeutic range. So you really have to do a thrombin time in order to demonstrate that. And a thrombin time that is normal means there is absent dabigatran. And you don't need to do anything. So these drugs for reversal, the FDA-approved drugs for reversal of dabigatran, I should have mentioned earlier that dabigatran is a direct thrombin inhibitor, in contrast to a factor Xa inhibitor, which is the apixaban and rivaroxaban, and edoxaban, but that doesn't seem to have penetrated the US market quite the same as the apixaban and rivaroxaban. Idursulizumab is a FAB fragment of a monoclonal antibody that was developed to bind very specifically as an antibody to dabigatran, and that has been available since 2015. And in 2016, this article was published, Andexanet alpha for acute major bleeding associated with 10A inhibitors. Andexanet alpha is like a decoy factor 10. It's a very interesting molecule. It's a decoy factor 10, and so basically it will bind the drug because it has a higher affinity for the 10A inhibitors than natural factor 10 does. Not quite as high as the affinity that idursulizumab has for dabigatran, but still. And it just pulls the drug out of the system, at least as long as that drug-drug complex is persistent in the circulation. It does not remove, other than what is circulating at that time, it does not remove anything other than the circulating 10A inhibitors from the circulation, and they have a very large volume of distribution, and you'll come to see in a later slide as to why that's relevant and one of the limitations of andexanet alpha. So this is from the article on idursulizumab. What it demonstrates here is that after you have given the infusion of idursulizumab, the measurable unbound dabigatran in the circulation, this is for patients who presented with spontaneous bleeding, but the same is true for the patients who presented needing emergency surgery and reversal. You can see that for almost up to 24 hours, you have cleared dabigatran from the circulation, and that really is quite impressive from a clinical study like this. Oftentimes volunteer studies are a little bit more encouraging because everyone has normal metabolism in these volunteer studies, but this is real-world experience of using dabigatran in patients presenting to the emergency room. And you can see that well, I mean, measuring the idursulizumab concentration is less relevant than measuring the dabigatran concentration. Moving on to the andexanet study, looking at apixaban here and rivaroxaban. This is just, you can kind of discard the upper two slides. They're just up there for interest. That's if you do a bolus dose. And this is a measurement of endogenous thrombin potential. Endogenous thrombin potential is a research assay. It's not something that's available for patient care, but it's a good way of studying the effect of these drugs on the ability of a patient's plasma to generate thrombin. That is the sort of the purpose of coagulation, is to generate enough thrombin that will convert fibrinogen to fibrin and therefore start the process of forming a stable clot. And what you see here, and I'm going to go to the bottom two slides because that is using the bolus plus infusion, which is the FDA-approved treatment. You can see that you're below the normal level. There's a very wide level of thrombin generation, which in itself is quite an interesting observation. And as you know, some people are more prone than others to thrombosis. If you're taking on a, if you've been taking like a standard dose of apixaban or a standard dose of rivaroxaban, this particular slide is from a volunteer study. What you will see is that the thrombin generation potential pre-infusion is abnormally low, and that's what you would expect in the presence of an anticoagulant. So what's kind of interesting is that rivaroxaban appears to be a little bit more effective than doing that, but these distinctions haven't ever really translated into clinical advantage as far as I'm aware. However, if you infuse andexanet with the red boxes here, what you do is you actually almost supranormalize the ability to generate thrombin. So you put someone into potentially a prothrombotic situation at the end of your bolus, and this is even more so with the rivaroxaban. So for the 2 hours, the duration of the infusion, you do a bolus plus a 2-hour infusion, you have the ability to really form a stable clot, which is ideal in the setting of somebody who's having life-threatening bleeding. However, when you stop the infusion, what you have been relying on is the fact that if you look at the placebo group, they are slowly recovering their ability, because you stop taking the apixaban once it's established. You're relying on metabolism to slowly return thrombin generation to its normal level by eliminating the drug that is circulating in the system. And that is a bit of a problem if you have any organ dysfunction. Anyhow, so however, if you look at the clinical situation, the stars here are representing the normal range, or a therapeutic range, from a trough and a peak of apixaban, and also from rivaroxaban. There's a bit of a broader range for rivaroxaban. What you see is that after you give the infusion, you're back up into a therapeutic range pretty quickly with the rivaroxaban, and also with at least almost 50% of the patients, sorry, 70, this is the upper quartile here, so at least 25% of the patients in the group are back in the therapeutic range after 4 hours, which may or may not be desirable. And you can see how, if you have somebody who's got a continued risk for bleeding, you know, there's some limitations here in this scenario, and it doesn't perform quite as well as you would expect from the volunteer study. Okay, other treatments. Andexanet alpha is not available in every hospital. It's also extremely expensive, but there are other treatments that were used prior to the introduction of andexanet. And what we see is that if you administer PCCs, this is non-activated PCCs, for example, what you would be using to reverse warfarin. Most hospitals have PCs available to them in a dose of 50 units per kilogram. Looking at the prothrombin time, you start to see a recovery of the prothrombin time here into a normal range after the PCC bolus. And similarly, if you look at endogenous thrombin potential, you see an increase in the endogenous thrombin potential in response to PCCs. This is limited. In the interest of time, I'm not going to go into this too deeply, but this is limited by the dose, by the circulating level of the drug that is in the circulation, such that if you have a higher circulating level of rivaroxaban in this example, you will not be able to reverse it with PCCs. You will only really able to reverse lower doses. So that is a limitation with PCCs. However, if you look at some real life studies, you'll see that actually, if you're looking at outcomes after patients who, you know, most of these patients, it was about 12 hours since their last dose, so probably the level of drug in the system would be pretty low, and it seemed there really was very little difference in terms of how many patients went home, how many went home with disabilities, how many survived in an ICH, intracerebral hemorrhage group, and in a GI bleeding group if they had received PCCs or andexanet alpha. This was a retrospective study, so it could be subject to bias. Okay, and moving on to the latest study, 2024, which is demonstrating. I'm going to move to again, in the interest of time, I'm going to move to the main slide here, which demonstrates that these were patients who were randomized if they presented with an intracerebral hemorrhage. They were randomized to getting andexanet versus usual care. Now, usual care, 85% of those patients received the 50 units per kilogram of PCCs. And what you're looking at here is that there's a greater, quote, success rate of hemorrhage abatement, as it were, with the andexanet than was with usual care. And this was defined as a 20% expansion of your hematoma. And it didn't necessarily translate into better mortality. And there wasn't a lot of information there about the details, like it was in the previous study, the details of the outcomes and the disposition of the patients after the study, which would be something hopefully that's going to be published subsequently to see whether there is a disability advantage of getting andexanet in this setting. However, it came at a price. There was an increase in ischemic stroke and in other thrombotic episodes, which is belying, it's just an example of the risk that we have using andexanet. Is very effective as a pro-hemostatic agent, and unfortunately that can lead to thrombotic complications. You have to decide clinically whether or not that is worth it. I'm just going to quickly go to, this is like a final slide. You put it all together. How do you manage this? First of all, you've got to know which drug you're getting. For the vitamin K antagonists, you use PCCs these days rather than FFP. That seems to be the #1 recommendation. For heparins, we all know that protamine will not fully reverse low molecular weight heparin, but it reverses about a third to a half of its effect, so it's certainly worth a try. Nothing else is approved to use. For dabigatran, if idursulizumab is available, you give it because it's very effective. That seems to be more widely available in hospitals than andexanet alfa, actually. If not, you can still use PCCs with dabigatran, but the data for that are less encouraging than for factor Xa inhibitors. Here, if you're on a factor Xa inhibitor and you've got a critical bleed or you need an emergency procedure, the recommendations is to go with andexanet alfa. However, if you do not have that available to you, or you're concerned about a potential for thrombotic outcome, you can go with the 4-factor PCCs in a dose of 50 units per kilogram. So it's possible that you could individualize your approach of using this very expensive drug that has limited availability. Would you be better off if you had somebody who had an earlier presentation or a shorter time frame from when they took the drug to when they presented, i.e. they're likely to have a higher circulating drug level? I think that makes total sense, but there's very little data to support that. And the key takeaways are here. Basically, the highest mortality is associated with intracerebral hemorrhage, as you may expect. You're going to see this if you haven't seen it already, because the penetration of DOACs into the market and the market of anticoagulants is growing as we age. The targeted medications have been developed. Idursulizumab is preferred for dabigatran, and andexanet is preferred for the factor Xa inhibitors. And 4-factor PCCs are available, but the data aren't strong. However, they're better than nothing. And I will leave it at that. Thank you very much.
Okay, our last panel is Dr. Cheruku, who just lost internet, so he's trying to reconnect. But in the meantime, I am gonna introduce himself. He is one of the medical co-directors of the CVICU at UT Southwestern. He's also an associate professor of anesthesiology, and he will be presenting on the evidence of hemostatic algorithms in the ICU. So we're just gonna give him a few seconds. Dr. Welsby, there is a question for you while we wait for Sri.
Sure.
Seems that someone is asking, from the drugs that you presented for reversal, do you know if they have been associated with more or less toxicity in older patients?
Toxicity, really, I mean, I'm assuming that means thrombotic complications. Yes, if you reverse the anticoagulant, we tend not to, for example, use andexanet in the perioperative space because we've encountered some thrombotic complications. We had a stroke in somebody who had AFib, and they were on anticoagulation for AFib, and they got a left atrial appendage thrombosis, and had a clot. This is more common in older people, be it DVTs, ischemic strokes, PEs, MIs. Are more so with andexanet than they are with the PCCs. That's the price you pay for a more effective drug, I guess.
That's for sure, yes. Okay, it seems that Sri is back with us. You can go ahead. I already introduced you.
Thank you. I'm going to see if I can share my screen now. Hopefully I won't lose internet again. So I want to thank the IARS for inviting me, and Ingrid for really setting this up and organizing, I think, an excellent panel here. My talk today is to discuss hemostasis algorithms in the ICU. I have no financial relationships, and sometimes I do discuss off-label use of Kcentra and Novo7, for example, but I think these are very common real-life uses, and I will kind of discuss them as such. So bleeding and coagulopathy are very common in the ICU. Transfusion is also common, and it's most frequently guided by conventional coagulation tests like PT, PTT, INR, and so on. And the transfusion of blood products is associated with significant morbidity and mortality in critically ill patients, and particularly so in surgical and trauma patients. So we'll begin our kind of talk here on measuring coagulopathy before we begin building an algorithm, and then we'll discuss the evidence for those. So these conventional coagulation tests, PT, PTT, INR, and so on, are useful for drug monitoring in non-bleeding patients. And they measure typically only procoagulant components, and they ignore the contribution of platelets, in vivo inhibitors, and fibrinolytics. Viscoelastic testing, on the other hand, which includes TEG, ROTEM, and then newer modalities such as Quantra, which is an ultrasound-based viscoelastic test. These measure time to initial fibrin formation, rate of clot formation, clot lysis, as well as the contribution of heparin to the coagulation. The way that we think about the coagulation system, it's an interplay between endothelial components, primary hemostatic components, procoagulants, as well as fibrinolytic, as well as, and these agents essentially are in an equilibrium that results typically in coagulation. We'll begin by discussing the capabilities and limitations of the viscoelastic tests. And ROTEM, I think, offers a very good example of what these tests can do. So we can measure the extrinsic pathway, in this case, when it's activated by tissue factor. We can measure the intrinsic pathway, which is activated in this test by lactic acid. We can measure the platelet contribution and the fibrinogen contribution to clot, as well as the heparin contribution to the anticoagulation. As using the A-proteinin, we can also measure to what degree hyperfibrinolysis is occurring. These tests cannot measure platelet aggregation, which is typically because of medications, or von Willebrand's disease. So using these viscoelastic tests has been tested in numerous observational and randomized studies, and I won't go over each of those studies in the interest of time, but there is a good systematic meta-analysis which has evaluated these outcomes in critically ill patients. And what they found was that using these viscoelastic tests reduced the number of patients in the ICU exposed to transfusions of PRBCs, as well as fresh frozen plasma. The same meta-analysis also evaluated trauma patients as well as surgical patients, and found that these tests were actually more useful in those patients. And there was actually a mortality benefit when viscoelastic testing was used in trauma patients. So as we build this transfusion algorithm, the most important is really delivering oxygen carrying capacity, or to improve the delivery of oxygen. And anemia is frequently the most often corrected here. Packed red blood cells are used to increase oxygen carrying capacity, and we know that unnecessary transfusions worsen outcomes. And we know this because of some large trials which are fairly well known. The TRIC trial, which compared the hemoglobin of 7 versus a hemoglobin of 10 threshold in critically ill patients, found that there was no difference in 30-day mortality among ICU patients within 72 hours of admission. The transfusion in septic shock trial similarly found that a hemoglobin of 7 was equivalent to a hemoglobin of 9 as a transfusion threshold in patients with septic shock. And the CRIT trial showed that when patients with acute coronary syndrome had transfusion thresholds between a hemoglobin of 8 and 10 compared, there was actually a lower composite of death, MI, or new CHF in the restrictive group. Without going over all subsequent studies, there's a good Cochrane review published in 2021, which evaluated the impact of liberal versus restrictive transfusions in published studies to date. And what they found was that there was essentially no difference in 30-day mortality and no difference in myocardial infarction. So the threshold that we use for various categories of these patients depends on the population. 7 grams per deciliter is good enough for most ICU patients. And 8 grams per deciliter is typically used for patients with acute coronary syndromes. And this is because the studies which looked at these populations happen to use those as the thresholds. The TRIC trial that you can see here compared to hemoglobin 7 versus 10. And the reality trial, which was published in 2021, used compared 8 versus 10 grams per deciliter in patients with acute coronary syndromes. Now, focusing particularly on cardiac surgical patients, the TRIX-3 trial is newer than the previously cited trials. And what they did after randomizing 5,000 patients with moderate to high risk undergoing cardiac surgery was that when they compared a hemoglobin threshold of 7.5 to a threshold of 9.5 for transfusion in the ICU, they found actually no difference in their composite outcomes. Importantly, for patients in the ICU, there was also no difference in ICU-specific outcomes that they looked at, such as the length of stay in the ICU. So now that we've kind of looked at what else, what threshold we transfuse to, which is typically a restrictive threshold, what else can we do to optimize the coagulation system? Dr. Welsby gave a very good talk on reversal agents. And I think those conservative steps are the beginning of optimizing the coagulation system in any bleeding patient. But there's some other things we can do. Calcium, replacing calcium and ensuring that there's no hypocalcemia is important because calcium is important for both platelet activation and also helps with factor 13. Similarly, maintaining an adequate temperature, avoiding hypothermia is very important in these patients. And I'll show you on the next slide, actually, the impact of even mild hypothermia on both clot formation and clot stability. And finally, the administration of antifibrinolytics early, sometimes even before laboratory tests are available, has been found to be useful in trauma patients in particular. This is a very elegant study using healthy human volunteers done where thromboelastography curves were generated by cooling the patient's blood down from 38 degrees down to 12 degrees. And what you can see here is that with every successive decrease in the temperature, there's both a prolongation of clotting time and there's also a decrease in clot strength using TEG here. PCCs are the next real component of a massive transfusion protocol, and I wanted to kind of begin to discuss that here. PCCs are plasma-derived clotting factors. There are 3- and 4-factor formulations available, and their concentration in these doses is 25 times higher than in normal plasma. They may contain heparin, protein C, and protein S to prevent activation. And the half-lives of the prothrombin complex concentrate components can vary. For example, factor 7 has the shortest half-life, while factor 2 has the longest half-life. To kind of illustrate the difference between these inactivated prothrombin complex concentrates and compare it to activated factor 7A, I have a little animation for you. So what the prothrombin complex concentrates do is simply replace and replete the body's level of various clotting factors. And as you can see here, this is just factors 2, 7, 9, and 10. And what factor 7A does in contrast to these prothrombin complex concentrates is that it activates the system. It actually forces us to go down the cascade, and it requires thrombin, requires fibrinogen, requires platelets in order to do its job. PCCs are faster and more reliable at restoring a normal INR than FFP with much lower volumes. There's a decreased infection risk. And these lower volumes are more attractive in heart failure patients, for example. And there's also a decreased risk of ARDS, probably, compared to FFP administration. There is a thromboembolic risk in when these agents are administered because of unopposed thrombin generation. It is this longer half-life of factor 2 that we discussed that extends typically beyond the massive transfusion period. And what we've learned from our experience here is that to avoid stroke and MI in these patients, use the lowest dose that's appropriate and stop administering these agents when the bleeding actually stops. Now, there are some studies evaluating 4-factor PCCs and comparing them to 3-factor PCCs. And for the most part, these 2 agents are similar in achieving a goal INR. This meta-analysis here actually shows that the 4-factor PCCs are slightly more efficacious, but for the most part, these are similar. There's also when the thromboembolism risk is compared between the 4-factor PCCs and the 3-factor PCCs, there's also a lower risk of thromboembolism with the 4-factor PCCs like Kcentra, but this was really not statistically significant in the study. When PCCs have been studied specifically in cardiac surgical patients, they also have a similar safety profile when compared to FFP. In addition to that, there's also a trend towards less blood transfusion with PCCs. And this suggests that using PCCs may result in faster time to hemostasis and therefore may reduce the use of blood products. Let's see here. And the use of these agents was also found in another study published in JCVA in 2022 that when you compare PCCs with FFP, there was better hemostasis, decreased blood utilization, less AKI, and a lower 30-day mortality. And what's happened in the last 4 or 5 years is more and more adoption of these prothrombin complex concentrates into routine perioperative cardiac surgical care, as well as inclusion into the transfusion algorithms that we'll discuss. Now, for the sake of completeness, typically the nuclear option in a transfusion algorithm is recombinant factor 7A. Now, recombinant factor 7A triggers 10A complex without contributing to thrombin stores. So it requires us to have adequate thrombin, have adequate platelets, fibrinogen, and more. It may not provide hemostasis when thrombin is deficient, and it can result in a much higher thromboembolism rate. And as we discussed, it requires the other components. With factor 7A, it's important that all the other options have been exhausted before using it. So now that we've discussed the various components of an algorithm, let's begin by building that algorithm. So any algorithm should begin with, is there bleeding? Is there coagulopathic bleeding? Because most transfusion algorithms and most experts will tell you that transfusing these blood components in the absence of bleeding is not recommended and does not result in good outcomes. Once it's established that there's bleeding, the next step should be to stabilize the coagulation system. In trauma patients, giving antifibrinolytics early has been found to improve outcomes, but also ensure that the patient is warm and that calcium stores have been replaced. And after these are done, the next step is to get viscoelastic testing, and there are various point-of-care viscoelastic testing available, both in the form of TEG, ROTEM, and this new Quantra system. We typically have one of these on wheels in our ICU, and that's how we make our decisions. Once the results of those tests are back, we need to replace cryoprecipitate or fibrinogen by giving cryoprecipitate first, because no clot will actually form unless you have adequate fibrinogen. Platelets should also be administered to ensure that you have enough platelets. And when clotting time is prolonged, 4-factor PCCs or FFP should be administered. And this really is our algorithm here. And when all of these things fail, factor 7A comes into play. It's unusual that the coagulopathic bleeding resolves after a single round of viscoelastic testing and product administration. And that's why this is really a continuous process of administering products, getting more viscoelastic testing, see what's missing, giving more, and so on. This is one of my favorite published algorithms. This is actually from Duke, and it's what I used when I was a fellow there, and it was actually published by one of my classmates after I graduated. And this is something that we use in our ICU. And just as we had discussed, it always begins with, is there bleeding, followed by viscoelastic testing, followed by the administration of these products as determined by viscoelastic testing, and then using factor 7A as the nuclear option, essentially when everything else has failed. This algorithm is not alone. In the past 4 or 5 years, there have been a large number of these algorithms published. And the one study I do want to point out is one that was published in Anesthesiology back in December of 2011, where they used viscoelastic testing and prothrombin complex concentrates, platelet concentrates, and so on to really drive a evidence-based transfusion algorithm. And what they found was that there was actually when an algorithm was used, there was actually a decrease in the amount of total blood products used, because they were wasting fewer products because they knew exactly what they needed. To kind of skipping ahead another 15 years, many of the studies published since then have also shown exactly the same thing, that when you use a algorithmic approach to transfusion, you reduce the use of blood components and you reduce costs as a consequence. There have only been a handful of good studies showing that there's a mortality benefit, and I don't have all of those for you here. And they're mostly in the pediatric population, but I feel like as we implement more of these algorithms and look at outcomes, eventually the reduction in blood product use is going to result or show a decrease in complications and perhaps mortality. So to summarize our talk today, point-of-care viscoelastic testing personalizes coagulation management, and it improves decision-making, and it's associated with optimal outcomes. Restrictive red blood cell transfusion does not change outcomes compared to liberal transfusion in many critically ill populations. In patients with coronary disease and those with NSTEMI, there have actually been fewer complications when you aim for a restrictive red blood cell transfusion strategy. Factor concentrates can safely be used to reduce blood transfusion requirements. And implementing a transfusion algorithm reduces blood utilization and also reduces costs. Thank you for listening.
Thank you so much to the three of you for your excellent talks. So I think we're going to start the panel now. Let's see. Okay, excellent. Okay, there are some questions from the audience. So I'm going to start with the ones that are in our Q&A box. I think this is a question for the whole panel. Is there any contribution of red blood cells in relation to hemoglobin concentration in blood coagulation? Meaning, is there a clinically relevant rheological effect of red blood cells in blood clotting during trauma or surgery that you know of? Does anyone want to start?
I can answer that, Ingrid.
Yes.
There was quite an old paper that was looking at hematocrit as a determinant of the ability to stop bleeding in not really in the trauma surgical population. It was more of an experimental setting. Honestly, I can't remember the exact details, but I think it was more like a bleeding time or something along those lines. And I think it was in patients who had like critically low levels of platelets. So there is a small amount of evidence there, but really it's not something that's been pursued. I don't think there's good enough evidence to say that you should drive your hemoglobin up to, I mean, I think in that particular study, the hematocrit was 40. I know certainly my older surgical colleagues who would love to see that happen, but not for any reason that I can understand. But there is something out there, but it's very old. It's very hematology based and more focused on sort of not the perioperative setting. So I guess it would be interesting to see, but I don't know that our red blood cell inventory and our blood banks can handle that kind of approach.
Yeah, in the congenital patients, we often see people with very, very high hematocrits, and although they are at risk for stroke, when they bleed, you still need to correct them, kind of pretty much the same way, for the most part, the same way we correct people without congenital heart disease. So it's an interesting question. Yeah.
Well, that's your area of expertise, is sort of adult congenital. So I mean, just to be clear with what you were saying there, is that you would say target a hemoglobin of 9 rather than a hemoglobin of 15 in an adult congenital. Okay, got you. Sorry,
Yes. Well, some patients actually need very high hemoglobins to live, especially when they're unrepaired. But for the most part, when they are repaired and they've gone through other type of surgeries where they have a more physiologic way of living, sometimes they can tolerate the same hemoglobin goals that we set for patients without congenital disease. But some patients are the exception for sure. Yeah.
There's always an exception.
This is a question for Dr. Furzan. Have you ever used bilirubin for ECMO or VAD runs? And if so, how do you monitor in terms of tests and frequencies of testing?
Yeah, we use it a lot for patients who are deemed pre-transplant, so to avoid exposure to heparin, so we can minimize the incidence of it. Luckily, bilirubin is very has a very nice pharmacokinetic. So usually we just start a drip, really low dose, 0.07 or so, and then we check a APTT. That's how we monitor. And we know the limitations of the test. If the patient is in a pro-inflammatory state, we probably have to look carefully to these levels. Could be supratherapeutic. Sorry, it's going to be falsely high. But I've noticed, and the data also reports that these patients reach the target anticoagulation much faster if they don't have any renal insufficiency, and they require less lab tests. And one of the studies also show that because they need less phlebotomy, they also have less anemia and they also have less blood transfusions. So yeah.
Sounds good. Excellent. And the next,
I would just, the only thing I would, we're now as an institution about to transition to using bivalve as our primary anticoagulation mechanism for ECMO patients. And so what we're beginning to use now is an anti-factor II test. While PTT is the gold standard and it's actually still recommended by many of the published guidelines, we're beginning to kind of experiment with the anti-factor II test to see if it gives you a better linear relationship, especially at higher doses of bivalve. We have an abstract out in the last few months showing that at least in our test sample of ECMO patients, the anti-factor II test has been fairly effective at predicting bivalve activity. But again, this is, I think, experimental, and maybe someday they'll have better data supporting its use.
That's a really, really interesting idea, Sri. So that's yeah. I look forward to reading about that. Who knows if it comes to be the next standard, but it's certainly a very interesting idea, because that's a prothrombin time-based clotting assay, right?
That's correct.
Yeah. Okay.
sounds good. The next question is for Dr. Cheruku. In terms of healthcare economics, what is the cost of FFP versus a PCC vial?
So, I can only give you our local costs. FFP, just the cost of a single unit is about $400, I think between $400 and $500. And for us, the PCCs, it's about $1 per unit. So that means that on average, if we're giving about 1,500 units of K-Cent or our local prothrombin complex concentrate, we're using about $1,500. So at least 3 times as much. Now, if that means that we can achieve hemostasis faster, I still think it's a very valuable component of a transfusion algorithm. What I'm seeing, and I know some of my co-panelists can attest to this, is the cost of the various powders, really the concentrates of platelets and fibrinogen and even the clotting factors. The cost is coming down with time, and I think eventually we will come to a time when there'll be vials of these various things stocked in our ICUs, and we'll be able to achieve hemostasis faster.
Sounds good. This is a question for Dr. Furzan, but I would like to know what the panel experience is on this. Do you use Humate-P, which is the concentrated von Willebrand factor in patients with acquired von Willebrand syndrome?
We've been using it more frequently. I think the commercial name is Bombendi, particularly on patients with non-pulsatile, who are non-pulsatile. And the idea is that these shear stress forces kind of elongate the von Willebrand factor protein and make it more prone to cleavage. So we've been using it, but I haven't found like prospective data or anything that justifies the use.
Do you use it instead of DDAVP or with the DDAVP?
We use both. Yeah, DDAVP and von Willebrand factor.
Okay. How about Dr. Welsby and Dr. Cheruku?
Go ahead, Sri.
Oh, we don't use it very much, and I don't have a lot of experience with it.
We've used it a couple of times. We unfortunately had thrombotic complications. I mean, obviously it's a very attractive option because it's addressing a known deficit, but it's really it comes with factor 8. So you can, if you already have a high factor 8 level, it can be prothrombotic. So yeah, again, with all these things, I think for example, using factor 7, which Sri referred to as the nuclear option in hemostasis algorithms, which I think is a fair description. We really started to have more success with that approach when the 1 milligram vials became available. The beauty of these sort of factor concentrates is that you can up titrate. I mean, you don't have to. I mean, the doses for the indications that are actually FDA approved are completely irrelevant to the sort of the trauma perioperative setting. And if you can, I mean, maybe if you had a vial of Hum8P, I would give a quarter of it and see what, and see what result you got. Because, and I think there's another question later on, which is talking about the diagnosis of coagulopathic bleeding, which is purely clinical. If you're not bleeding, you don't need to treat anything. Within reason, platelet count of 5 or something, but still, I think that is the tenet of this management, is if it ain't bleeding, don't fix it, sort of.
Yeah. Okay. What are your thoughts on ECMO runs without heparinization or anticoagulation? This is for the three of you.
I think we have more data for VV. I think it's safe. But all this data is retrospective, right? So we don't have any prospective data. So for VV ECMO, probably we know it bleeds more. It has more intracranial hemorrhage. If we keep some the flows at an appropriate level, and we make sure that the patients are the coagulopathy is treated, I think if the patient is deemed high risk for bleeding, I think it's safe to stop it. And then the study I showed, at least the patients were on DVT prophylaxis. For VA ECMO, I think I think we would need probably more data. Yeah.
Okay.
I agree. And I think, as Dr. Furzan pointed out in his talk, when it becomes necessary to hold anticoagulation, maintaining higher flows on ECMO, I think is a good idea. There's about 10 observational studies now showing that somewhere over 3 liters per minute of ECMO flow, or as Dr. Furzan's talk said, an emptying time of blood every 20 seconds on the circuit is necessary. So that would be the one point of caution I would add.
Okay.
Yeah, I mean, it's not your first choice, right? So pretty much everybody gets anticoagulated during the initiation of ECMO. So you have to wait for that to wear off. So that in that setting, most people, when they're initiated, do get anticoagulated. I think that you've got a perfect opportunity, the Virchow's triad, to be sort of active in this setting. And if you have stasis anywhere, that's the problem. And your point about 3 liters of flow is great, and I think that's totally appropriate, particularly in VV ECMO. But if you have to avoid anticoagulation in VA ECMO, you also must maintain flow through the pulmonary circulation. So you really have to try and get the heart to do something. Now, whether that's with some additional support or an LV vent or an impeller, or however you care to unload the LV, or even though you're on ECMO, you still need like 0.1 of epinephrine to make it sort of flutter that aortic valve from time to time. I think stasis is the main concern, and you've got to think about the pulmonary circulation as well, which is obviously not a consideration for VV ECMO, because that is very generously fused.
Sounds good. Have you had experience? Let's say, for example, when a patient is critically ill, they were bleeding, you gave the reversal agent, and then you have to emergently go on ECMO after you have given the reversal agent. So have you had experiences with that where you have issues flowing or any problems with the use of a reversal agent before an emergent ECMO run?
Huh. That's a bit of a nightmare situation.
Yeah. Yeah.
Thanks for that question.
No, anyone?
Dr. Furzan, I mean,
Not really. I know that there was a study about the safety of andexanet for cardiopulmonary bypass, and I think the conclusion was, if you're gonna go on pump, try not to give it, because it's gonna be clotting everything. But I don't have experience.
Actually, there's a specific point to make with andexanet and cardiopulmonary bypass. It also reverses unfractionated heparin, so it's a nightmare to use. You have to use a ludicrous dose of of heparin in order to anticoagulate and get your ACT into an acceptable range. It really should not be used in the pre-bypass sort of situation. If you determine that you have to use it in the post-bypass situation, it will be effective. But it may cause thrombosis. I haven't done that because, well, actually, that's not true. We've done it one time and we'll never do it again. But other centers have reported that. I think we unfortunately had mixed, and this is an important point as well, is that this patient had received PCCs, they were still bleeding, and the hematology consult sort of approved the use of andexanet, and then they clotted everything when they gave it. So it was a disaster in combination with other stuff because that was really cranking up the prothrombotic aspects of things.
Okay. There is a question here. Do you use prophylactically the direct thrombin inhibitor alternatives in pre-transplant ECMO runs? Because have you ever used that?
Usually we just switch when the PA4 is positive. But I think we're gonna try to move towards that also, DTIs.
Okay.
Because we've had a lot of incidents of hate.
Okay.
That's a really good question. And I think also there's also the heparin associated thrombocytopenia, right? So it's not the immune thing, it's the HAT instead of HIT. But I mean, it's still real. And you can give bivalirudin to somebody while you're waiting for the labs to come back and their platelet count increases. So it's whether that's platelet clumping or platelet clearance, it's not entirely clear. But I mean, you can certainly increase your platelet count. So it totally makes sense. That's a great suggestion.
Okay.
And I know Mayo do this, right? Mayo Clinic pretty much do bivalirudin for all their ECMOs.
Okay. Any data on alternatives to heparin anticoagulation during ECMO runs for acute PE?
Yet another great question. I think this person is really is nailing it, but I'm not aware of any data.
Me neither. Okay. That's good. There was a question that Dr. Welsby answered in the Q&A that I think it's good to discuss. For a patient on a Pixavan who presented with a massive GI bleeding and will need a massive transfusion with essentially whole blood 1:1:1 resuscitation, would you still recommend andexanet or PCCs? And do we have a sense of that? How much will that add? If you want to share your answer with this.
Yeah, well, so I mean, I just said that, well, first of all, that's a very difficult sort of scenario. And it's also kind of unusual to have a GI bleed, which is so brisk, unless you have like an arterial bleeder, which, I mean, in my mind, you get them to the GI suite and you can clip it. I mean, that's the thing is you can fix a GI bleed if it's something that you can put a clip on. Like a Dulafoy lesion or something like that, or an acute ulcer. I think it would have to be something like that for such a brisk GI bleed. And then the problem is going to be trying to persuade the gastroenterologist to take him to the GI suite unless you reverse the anticoagulation. And I think they're coming around actually with time. They've all seen the thrombotic issues with reversal. So they tend to do that. However, if it's somebody who's got like severe acute diffuse gastritis, for example, and you're pushed into doing it, I would personally favor the PCCs because it has a lower thrombotic risk. And then I would also really want to get more information. It's not as critical as an intracranial hemorrhage where you have to sort of act immediately to sort of, save the brain, and a couple of units of blood here and there. I know we don't want to waste blood, but in this kind of setting, a thrombosis is pretty tragic as well. So I would lean away from the very effective andexanet because, there's more of a thrombotic risk and it depends on the details of the history. Have they had a recent MI? Have they had a recent PE? Whatever. What is the indication for anticoagulation? Was it just like AFib, prevention, which is not such a big deal, although it can be, versus like a PE last week? I mean, I think you've got to really take that sort of thing into account.
Okay, it seems we've run out of time today. Thank you so much to all of you for this great panel. We learned a lot today. And I want to thank all the participants who stayed with us all the way through the end. Thank you, everyone. Have a good night.
That was great. Thank you so much.
Bye.